So today I'm really pleased to be able to introduce Laura and Adam. Laura Finucane is a consultant musculoskeletal physiotherapist and the clinical director for Sussex MSK Partnership in the UK. Recently, she's involved in the global strategy to improve MSK health. And that strategy recognises that if we want to improve people's MSK and wider health, we need to do things differently. And at a local level, Laura has experimented in how we deliver that care that supports people with their MSK condition and beyond through the creation of community appointment days. Then we also have Adam Lent, who's a senior consultant at the King's Fund, who was previously the chief exec of New Local. He's been working for the last 20 years on public sector innovation and reform with a particular focus on community-led approaches, new models of leadership and organisational culture change. He's done a lot of research and written extensively and holds a PhD from Sheffield University. So the plan for today is we're going to hear from Laura, then Adam, and then myself and Bianca are going to host a conversation with Laura and Adam, and you can stay with us, to delve a bit deeper into the process and the details of developing the community appointment days. If you've got any questions, put them in the chat and we'll pick them up as we go along. So I'm really delighted to hand over to Laura.
Thank you. Thank you very much. And thanks for the kind invitation. Hopefully you can see my screen. I actually do have a colleague who's also in the audience called Charlotte, who is one of our clinicians who has experienced these days. And I think it's sometimes quite helpful to have someone who's been on the receiving end of actually delivering this day as well. So, you know, she can pick up some of the questions, I hope, as we go forwards. But for those of you that are not familiar with the community appointments days, basically we invited 300 people on a day to off our waiting list, of the MSK waiting list, to come and have an appointment in the community. So very much in the community based, but basically what we wanted to do was to support people beyond their MSK condition. So not just about their MSK condition, but beyond that as well, with a focus around prevention and health promotion, with access to sort of local community services that could support people depending on what their needs were. What we know is that these days have been creating some interest, mainly because what it showed is that our waiting lists were hugely reduced, having done a number of these days. So when we started these days, we had 19 weeks on a wait list. A year later, having done about 6 events, our wait times were down to 8 weeks. So significantly reduced. But I think what's really important is that this was never set up as a waiting list initiative. And I think I'll talk to why we think that it had an effect on the waiting list. But this was much more about delivering a different model of care, actually. So what we knew was that the way of working was really unsustainable with these long waits for patients. Clinicians were really feeling the pressure of an industrialized model of care that really focused more on productivity than the person that was sat in front of them. And so what we recognized is that people were coming with much more than just an MSK condition. You know, people, don't just walk into a clinic room with an elbow. You know, there often are lots of other things that are going on for those individuals. And often those individuals get bounced around the system, and with multiple sort of interventions that don't always get to the bottom of what's going on for them. So we wanted to deliver this different model of care that really put the patient at the heart of and focusing on personalised care, essentially. Not just a kind of tick box exercise, really thinking about working in a very different cultural way, both for the clinician and for our non-clinicians and for our patients. So whilst the CAD I'm going to talk to that, it's really, I think this is a byproduct of the model that we wanted to deliver. And I suspect there'll be many different ways of delivering the concept of what we wanted to deliver, in lots of different ways. It's not rocket science, I don't think. So what you see in front of you is what I believe is will help or what the essential ingredients were to deliver those days. So I'll talk to some of those things. Just hang on a second. Oh, I would do if it would just go forward for me. There we go. Okay, so the first thing was around sort of this personalized and humanized, unhurried human care, basically, and which might sound a bit strange, but I think, often healthcare within the NHS can feel a bit like a conveyor belt, with the focus on getting people into the system and out the other side. So really focusing on that productivity as opposed to the quality of the intervention that individual is receiving. And so we wanted to remove those barriers that were getting in the way of that sort of humanized care. So things like time constraints. So people have clinics that are set up 4-hour clinics and they see a patient every 30 minutes. We wanted to kind of remove the time constraints and allow these people to have as long as they needed, and for clinicians to take as long as they needed to get to the bottom of what's going on for that individual. We wanted to get rid of things like writing notes, for example, for clinicians sitting behind a door and behind a desk and with a computer writing those notes. So really just stripping out all of those things so that people could be really present with that individual. So that what they were seeing was the whole person, and they actually understanding what was going on for that individual in the wider context of their life and supporting them from that lens. And so the focus was really about what really matters to that individual. It was about front-ending the kind of the whole intervention with a what matters to you conversation. So the first thing somebody got when they came into the sports hall was a what matters to you conversation with somebody, and very much focusing on what was it that they needed. And it might have been an MSK condition, but it may not have been. It could have been something completely different that actually was more important for them at that time in motion. And really those conversations are really based on a strength-based conversation in that it's about health coaching, motivation, change behavior, all of those kind of things that really support people to help them manage their symptoms. And so what we're talking about is moving from that consultation to a conversation. So really demedicalizing exactly so the conversation. So not sort of going into details about, tell me about your knee pain, tell me about this, much more focused on, tell me what's going on for you and what have you tried. So really thinking about being present with that individual. We wanted this to be explicitly community powered. So this wasn't about shifting, coming out of the hospital, lifting and shifting into the community. This was about doing it differently, but really thinking about those asset-based situations where we could invite our community and voluntary sector to this event to support those individuals, and really, really being specific about that. So we had a range of voluntary sector and community services that came and supported the event. So we had I'm just trying to think now. So we had health and wellbeing, we had social prescribers, we had a Citizens Advice Bureau, we had DWP, we had pelvic health there, we had podiatrists, we had Age UK Concern, frailty service, we had Men's in Sheds, we had the yoga group, we had all of these things. So a real whatever was facing that community, we invited them to come and say, could you support this event, and see how people would visit them on that piece of the journey. So a great range. We also said that this was really about letting go of the ego. And again, this for me is about demedicalizing. This is about recognizing that individual comes with as much expertise about what's going on for them as I have the expertise to impart my knowledge on my side. So it's about recognizing we're equal partners in this conversation and that we can navigate this together, and we're going to go on that journey together. So that real therapeutic alliance in which we support individuals and enable them to take the journey with as much support as is required for that person. And that person might need a raft of things, and I'll sort of talk about that in a second. The last bit is really about the being led by the data. We think this is really important. We basically cover a geographical area that is really diverse. It's really different. So we have one area which is a young population, but there's a high homelessness and drug abuse. We have an area which is very wealthy, but with an aging population, and then we have another area which is very deprived and with a high ethnicity. So each of those areas are, essentially very, very different, and it's about understanding the data and knowing who's coming to your services and who's not, and why they're not coming, and how you can support them to actually come to these events. And as I said, it's about that local flavour. It's really thinking, well, what's going to work for those individuals? And some of the data that we know is coming out sort of nationally is showing that people with an MSK condition or osteoarthritis often are clustered with other conditions. So we know there's a cluster between osteoarthritis, diabetes, and cardiovascular disease. So there's something about, how do we bring those other services into this arena to support those individuals? Because even if they've got one or two of those, then you're going to manage those. And the other really big thing for us was around our staff. So this was as much about our staff as it was about the people we were seeing. What we recognised leading up to this event was that post-COVID, our staff were feeling really burnt out. They were feeling quite demoralised. They felt like this was relentless. The weights were really high, and it just felt like we're never going to get to the end of this, and this is really hard work. They felt isolated. They felt like they just had no connection with the team. And actually, here was the opportunity to do something differently in a non-pressured time event where they could connect with each other and support each other. And and I'm hoping Charlotte will kind of sort of confirm this. But what I saw in the room on these days are individuals connecting with each other, supporting each other in some of those difficult scenarios where they're not quite sure what's going on, and actually watching around the room to see who needs help, and actually where do I need to go to support an individual or a member of my staff to do that. So for me, there was as much joy in seeing how the staff were connecting and felt more connected in a team than anything else, if I'm honest. So that's really, those were the ingredients that we felt were really important to really draw on in terms of developing one of these days. It's not about lifting and shifting what you do currently in the hospital and just doing the same old thing in a sports hall. It's trying to do things very differently that is really patient focused and personalized to that individual, and then having those things in the room to support them. So we had rehabilitation, we had the ability to do an assessment if we felt that was needed. We could give advice and guidance. We did health checks, so people could have their diabetes checked, they could have their blood pressure done. We would give some health promotion information. So the real raft of things that were going on for those individuals was in the room on that day. And as a consequence, and I'll just give you a soundbite in terms of the data, 50% of the people who came to see us were put on a patient-initiated follow-up and basically have not come back to us. I think there's about 10% that have come back to us out of that 50% as a consequence. They've got what they needed in the room on that day. So that's been really helpful. And about 30% of those individuals, of the total 300, had an intervention or conversation with somebody from the community to support them on their journey. So I'm going to stop there, and I don't know whether, Charlotte, you would like to add anything whilst I've got you here. I can see you.
Hi everyone, thanks for having me today. Yeah, no, it was an amazing day to be a part of. It was like we were saying, doing things differently. We used to close clinic doors and hard to interact with people due to clinicians, senior clinicians. We have a list of problem patients, and for someone that's more complex, it takes, like I said, that pathway of getting them to the right place. So just being a part of the day where everyone is in the same room, it was a bit nervous to start with. Like I said, we just didn't know how it was going to run, but it was so lovely not to have your laptops and no time constraints. It was lovely just to again have just a really nice conversation with someone again about what matters to them and how we could get them to the right place. And it was so nice if there was a problem, like we have to use our clinical knowledge if we need to, again if something more serious presented. But it was so nice because you could go to the advanced practitioners were there, if it was mental health, you could just walk over and have that joint discussion with the mental health team, or aged care, or anything that they wanted to address. If it was just rehabilitation, you could take them to the rehab centre and get them started on exercises and give them guidance. So it was absolutely lovely just having everybody there, and for our learning as well. You know, you wouldn't have been able to do that in normal clinics. That would have been several different appointments just to get them to that place, but you could just do it all in one day. And it was yeah, really, really great to be part of.
Thanks, Charlotte.
Thanks so much for sharing that, Charlotte. It's really interesting to get your feedback on how it feels to move into doing the community appointment days. It's such a different approach from normal ways of working. Now I'm going to hand over to Adam, who's going to talk to us about how we can use those strength-based community power principles to look at how we provide care and address short-term demands. And I think he's got some examples for us as well.
Yeah, absolutely. New local, oh God, I got a massive, my face just came up massively there in front of me, which is very disconcerting when you're talking to you. New local profiled the community appointment day on our website at the end of last year, and it got generated enormous amount of interest. And one of the real benefits of that is that it generated a whole load of other examples that came out of teams working in the health service and in local government that are doing things that are not identical to the community appointment day, but have some similarities. And I think that firstly, that told me two things. One is there is a real wave of innovation happening in the health service, despite all, or maybe because of all the challenges and problems, and in local government, and that's great to see. But I think it also showed me that, to use Laura's term, you know, this is not about lift and shift. And I think Laura and her colleagues, you know, are very clear and very passionate about this, is that this is one approach. There are other ways of addressing the sorts of challenges there are around short-term demand and other challenges there are around primary care and other sorts of care. And it's really about understanding those principles and applying them in different contexts and different places, rather than saying, oh, here's a model, let's just try it here. And in fact, I did actually hear about an example. This is sort of negative. There's lots of positives, but I'll just start with the negative. I did hear a couple of days ago about a case of a physiotherapy team in an area that shall remain nameless in the country that were told that basically from on high, they were told they are doing community appointment days. And the reaction has not been good. There's been a backlash against it. And I think, you know, that just shows how these things need to be co-produced, they need to be co-designed, they need to be context specific. You can't just say, oh, here's a good idea, let's do it here. It doesn't really work well when you do that. But on the really positive side, there are loads of examples of similar sorts of approaches. One of my favorites that came out of the conversations that I've had following the profiling of the CAD in Sussex is the pop-up surgeries in Barking and Dagenham, which some of you may have heard of. If you haven't, really exciting initiative. It's basically the council, Barking and Dagenham Council, local GP surgeries and the voluntary sector getting together. So it's a real case of integration in practice. And what they're doing is really about addressing access to primary care, because Barking Dagenham's a very diverse area of the country. There are many, many communities in that area that actually don't have good access to healthcare. So this is about improving access, it's about giving better care, but it's also about prevention, because clearly when people don't have access, they're more likely to get ill, they're more likely to develop complications. So what they've done in Barking is they hire out a space. It could be a leisure centre, it could be a community centre, in particular areas where communities, the community they want to link up with live, and they literally leaflet the area. They go around the area saying, if you'd like a guaranteed GP consultation, come along on this date to this centre and you'll get a GP consultation. But very similar to the CAD, they also have the voluntary sector there. They have lots of community groups, neighbourhood networks, support networks, and members of volunteers from the local voluntary sector and charities are trained in strengths-based conversations. So it's almost like the bait is to get people to come and have a GP consultation, a traditional medical consultation, but they also have the strengths-based conversation with a volunteer, and they get linked up with some sort of community support, whatever it is sort of support or care they need. And there have been loads of these carried out now across Barking and Dagenham, very effective. They've done them recently. They did one recently with the homeless community, which is sort of really interesting. And just to highlight how lift and shift doesn't work, their own model didn't really work with the homeless community, because what they discovered is that homeless people do not want to have a consultation with a GP. It's not generally their experience with medical professionals has not been positive. So they had to completely redesign the model. So it was more about, bringing people in, having those strengths-based conversations, gradually drawing them in to a space where ultimately they might feel comfortable to have a medical consultation. So, really interesting example there. Another example is the Wellbeing While Waiting scheme. So this is aimed at CAMS, Child and Adolescent Mental Health Services. This is now being piloted and tried out in 12 different trusts around the country. And this is more of an individual basis. This is about contacting young people who are likely to be on CAMS waiting lists for a long period of time. So not the most severe cases, but these are people who, if they sit on the waiting list for a long period of time, are likely to develop more severe conditions. That's one of the problems of long waiting lists, obviously. So these teams are reaching out, the Wellbeing While Waiting teams are reaching out to people on waiting lists and having that strengths-based conversation with them. Not a medical consultation, what's going on in your life, what matters to you, and then out of that conversation, linking them up with a network, a support group, some sort of community group that might be able to support them and help them. Now, the aim here is not necessarily to get young people off of the waiting list. That might happen, but really, as Laura said, it's about providing better care, about addressing the problems and complications that might emerge when people are sitting on waiting lists for too long. And then I'll just give one more example. I could go on forever. One more example. And I mentioned this one because this was quite important. This is an older example, but one that was quite important for me and for New Local in developing our thinking about how care and public services should work. So the Mayday Trust, many of you may have heard of. It's actually now merged with another organisation, but the Mayday Trust was quite a traditional homelessness organisation. And when it had homeless people referred to it, it basically try and find them accommodation, as is often the way when homeless people are referred to homelessness services. They completely changed their approach. They decided to go down a strengths-based route, treat a homeless person as a human being with their own strengths, their own complex life story, their own needs beyond homelessness. And what they found through doing that is that actually, very similar to the CAD, is there's a whole range of issues in people's lives beyond homelessness, which might be making their lives challenging, and they have strengths themselves which can address those challenges. So just one very quick example that I found particularly inspirational: person who'd been homeless for many, many years, suffering, enduring drug and alcohol abuse, had a truly very, very difficult upbringing. They had a strengths-based conversation with her the first time she had a genuine conversation about her life, rather than just being referred to A&E or to the homelessness service or to the police. And what they discovered was that she loved chess, that when she was young, she had been at school, she had loved playing chess. So rather than find her temporary accommodation, which she would almost inevitably leave, as she had in the past, they just took her to the local chess club. And that was the thing. It didn't change her life overnight, of course it didn't, but it was the thing that was the beginning of a turnaround in her life, something that gave her a different focus and introduced her to a different community of people that was much more healthy and wholesome and supportive than the community of people on the streets who were abusing alcohol and drugs. So that sort of shows you, I think, how you can take these principles and apply them in different ways to have a real impact on prevention and short-term demand. And if I just say very quickly, what I think those principles are, and I'm still sort of working these through, so it'd be interesting to hear other people's views. I think broadly the underlying principle in all these schemes is about working with or doing with rather than doing to. So much of what we do in the public sector is about doing things to people because we think we're the experts who know best. And what these initiatives are about is about doing things with people because you recognize they have strengths, they have ideas. As Laura said, they're the experts in their own lives. So let's use that to find ways forward to them. So that's the sort of underlying principle. And then the three things that make that work, and I think this is common to all of these initiatives, these three things. It all starts with a conversation that is about Am I still there? Something weird suddenly happened on screen.
Still there.
Yeah, it's about listening and really about understanding. It's about understanding what matters to the person you're speaking to rather than what matters to you as a public sector professional. So that deep understanding, listening conversation is the starting point. Once you've got that understanding, it's about being flexible in your response. It's not about necessarily referring them down an established pathway of medical care or whatever it is. It's about thinking, okay, what is it that's going to make sense for this person and their needs and their concerns, and having a variety of different responses, whether that's community care, more conversation, working with their family, whatever it is key. That flexibility of response is key. And then finally, it's about working out how that flexible response can be delivered in collaboration. And that could be in collaboration with the particular individual you're working with. It could be in collaboration with the family. It could be in collaboration with a wider network, or it could be in collaboration with a community, with a charity, whatever it is. But it's always about looking beyond your institutional resource and thinking about what's the wider resource that this individual or the community brings to delivering that really hyper flexible response that's based upon that deep understanding you've built through a proper what matters to you conversation.
Thanks, Adam. That was ever so interesting, particularly when you were saying about not doing to people, but considering what matters to them. And it really just took me back to what Laura was saying about having to let go of our ego and have some the whole process. So I think it's now time to look at some questions. Bianca, are you okay? Just give a little wave there. Brilliant. So everyone knows who you are as well.
Hi, everyone. I'm going to just support some of the questions that people have brought to the table here. Thanks, Laura and Adam, to share your experience in terms of how you've led these community-based approaches. I personally have quite a few questions to ask either of you. I'm quite curious and impressed with the piece of work. But I can see, Laura, you and have answered some of the questions in the chat. But I'm just scrolling through the chat right now, and we have a question. Just bear with me. So I think there's a question from Paul about how do you bridge the gap between those identified through the data and those not showing up in the data?
So, I guess what we're keen to do is to identify why people aren't coming to us, and what that data tells us that actually those who are more deprived tend not to come to us. We know that men don't come as much as women. We know that certain areas are, they make an appointment then don't turn up. Their DNA rate is higher. So what we're tending to do is to go into those communities where we're seeing those patterns and actually working with them to find out, well, how do we support you to come? What is it you need from us that will enable you to do that? So it is about sort of using that data to really drill down into, well, you know, what is it that's going to be helpful for you? And I know we've been doing some work around people who are not digitally or who are digitally excluded, and you know, again, what do they need? Because they need something different. And if they need something more from us, what is it that they need, and how can we get them there? So I think it's a bit of a journey around, you know, identifying what we're looking at from the data, but some of the data is really powerful. And really helps us to focus where we need to go. You know, I think traditionally, you know, people come to the health service who are well educated, they're knowledgeable, they know what to expect, and you know, they're more likely to come. Whereas the people that really need us aren't coming, and so actually, what we're trying to do is to think about what's the offer for those that really know how to look after themselves. There's a different offer to those that perhaps need more help, and I think, you know, that's where we're trying to lean towards, is reaching the people that really don't normally access us and actually do need us. And fundamentally, there's a whole raft of information about why people don't come, you know, and actually it's working with that data, I think. I hope that answers the question. Adam, I don't know if you want to answer more to that.
No, I think you're the expert on that one.
Yeah, but it just sort of emphasizes what you said at the start, Laura, about, you know, taking it back to what matters to them and redesigning your service. So that's what I'm hearing. And that's really quite powerful in ensuring that you're making it easy for them to access you. So that's brilliant. And I've got another question here from Erica, and which leads very nicely into, in terms of staffing and structuring this service, how did you manage that? So did you experience any bottlenecks, or were you able to respond to the variation that you were experiencing in terms of demand?
Yeah, so I have to say this was a bit of a finger in the air kind of thing, but what we wanted, we made an active decision to get all of the staff who normally worked on that day to attend the CAD. So we didn't kind of go, right, we need X number of staff. We kind of worked it the other way. We said, right, who's available, who's capable of having those what matters to you conversations, because there is a skill in that. It's not as simple as just, you know, as Adam said as well, not lifting and shifting what you normally do. It's a different conversation that needs different skills, and you know, we spent a lot of time honing those skills for those individuals, and so we knew that we had a kind of a really good group of people that could have those conversations. So we centered them around that. We had about 20 people that could do that, and then we had a smattering of people doing an assessment, some doing advice and guidance, some doing rehab. So a real range of people, but just sort of allocated people where their strengths were. And then we made a decision, right, we think with 20 what matter to you people that we can manage 50 in an hour. Let's try it, suck it and see. And that's pretty much what we did. And there were some, when I say bottlenecks, some people did have to wait, but what we did was we stewarded those people around. So we had people who were there, you know, asking people why they were there. Was there anything else that we could help them with? Did they need anything else? You know, what was in the room? And where we seem to have the bottlenecks, it didn't last very long. So I got quite anxious at points, thinking, oh my God, there's 30 people waiting. How long are they going to be? But actually the turnover kind of it just worked. And where we found some people were quieter, they just went over and supported the what matters to you, or they've supported the advice and guidance, depending on where that was. So there was lots of flex in the room, and we made it very clear to people, you know, you might be here for a bit longer, you might have to wait a little bit, but actually you will get what you need in the room today if you're prepared to stay. So again, it was, you know, really stewarding, making sure people understood what was going to happen within that context, really.
That's brilliant. So it's about being agile in terms of your skill task allocation and responsive to what's coming in. So that's quite interesting. The next question is from Zoe, and it's really about, how did you know who will require further assessment? So was this the patient making that choice to follow up further, or did you manage to gauge that in terms of numbers on what you did on the day?
Yeah. So everyone had the what matters to you conversation, and essentially, if the person who was having that conversation thought that this person's condition is deteriorating, or they're showing some signs that we're worried about them, then we would pass them to the Let's Assess. So we get an assessment. So we hired some booths to do those assessments. So we had plinths there, so we could fully assess those individuals. We also, if patients were really kind of adamant that's what they wanted, then again we would pass them into that. And I think I think it was something like between 25 and 30% of those 300 had a full assessment. And again, they might have experienced other things, but essentially we tried to kind of keep that minimized. And those individuals that did have an assessment had their normal notes taking, whereas those that didn't, basically, and you might have seen it, I put it in the chat, basically we enabled patients to take their own notes. That was the whole point of this. This wasn't about clinicians sitting behind their laptops and taking notes. This was about that being present and asking patients to take some notes in what we called a passport, and they could write down the key interventions they had. And by the time they left the room, they'd have populated this passport. We photocopied or scanned in the sort of middle section, which had all of that information, into their usual notes. So we had a record of what had happened to that individual, essentially.
That's brilliant.
Can I just jump in here?
Yeah, sure, Jo.
Oh, thanks. You mentioned about training to staff, so they felt that they were skilled to be able to do the what matters to you conversation. Was there any other prep work that you had to do before these community appointment days? Because I'm sure they didn't just come out of a quick process, but were maybe part of a longer term culture change.
Yeah, so I think for me the key thing was around the personalised care piece, and I think this wasn't new to us. We've been sort of we've embedded personalised care for the last 8 years or more, basically. So we've had that sort of background, which was helpful. But we also, we did do some specific sessions around it leading up to the CAD day. So there was some intensity around doing that. In terms of, and we also the other thing we put in place was we had self-booking. People were able to, we sent them a text and they were able to self-book onto that day and decide, when they could come. So that really helped some of the processes. In terms of each of the sections, we had a lead for each of our sections, a rehab assessment, etc. And it was their role to work out what do we need in the room to support that. We had nursing staff and some students doing things like the diabetes check and blood pressure and health promotion. We had podiatrists there. So each of those individuals really brought what they needed into the room for that day. So that didn't really require huge amounts of training. It was just more about thinking about what am I going to need to enable me to do what I need to do in that space, essentially. And the advice and guidance, again, it's nothing, not rocket science. It's stuff that we would normally do, but just having those consistent messaging and resources for advice and guidance and health promotion, etc., essentially. So Charlotte, was there anything, because I might have missed something, anything else that you think we had to put in place that was different to what we'd normally do apart from the personalised care? What matters to you?
No, not really. Like you said, yeah, we had some of the coaching and training to be able to obviously handle those conversations. But like you said, I think it was just the groups before, wasn't it? The rehab teams, the advanced practitioners kind of, meeting with all of the age UK mental health. It was just kind of that conversation, I think, and prep in kind of the teams, that because we all kind of knew where we were going to be before. So it's nice just to have that contact with other clinicians, say, oh, you'll be advanced practitioners today, they'll be leading that group, or rehabilitation, they're going to be there today. So yeah, it was just kind of prepping the people we knew where we were going to be beforehand.
I think the one thing that perhaps we underestimated or sort of thought would be all right was people would turn up and go, well, what's this? Why am I here? And despite that, what we felt, we thought we really prepared this well in terms of, saying what to expect. We'd sent text messages and it would take them to the site and it would be all there. And so we got better at stewarding. So as people arrived, we would say, did you click on the text? Yes. Did you read what was on there? Well, not really. And so that allowed us to say, right, well, this is why you're here. This is what to expect. This is what's going to happen. And for every sort of section, people were stewarded in that area just to kind of guide them and get them ready for the next bit of that journey, essentially. So we really started to tweak that a bit more as we did more days to get there.
That's brilliant, Laura. And then we have a few questions around the logistics in terms of what time of the day did you run the CAD days? What days of the week, perhaps? And what was the criteria? So did you invite everyone on the waiting list, or did you start with a targeted population?
Yep. So we run longer days on a Monday and Thursday. So we went for those because it meant we could carry on till 7 at night, essentially, because that would be people's normal working day. And so we sort of set up in the morning. We started at 11 with the staff, and patients arrived from 12 onwards. And as I said, around 50 every hour, roughly. Sorry, what was the other question?
So in terms of criteria, did you invite everybody, or did you start with a targeted list? Like,
so no, we weren't selective. We just we took the people who were waiting the longest, and we just populated it that way.
Brilliant. Yeah, that sounds amazing. So I guess I have with my QI mind hat on, I have a couple of curious questions for you and Adam. I guess, and in the current NHS climate, this is happening to all of us. We've got to think about optimizing our resource. So against your current competing priorities in the service, which I bet you have many, how have you approached, delivering your CAD service as well? And that's something I think everyone will benefit from hearing in this space here.
So, I mean, we're in a bit of a we're in an interesting situation at the moment. We're under procurement. We're waiting to see whether we've won the next contract, but irrespective of that, the push is around waiting lists. That, people waiting too long. It's as simple as that. And it doesn't matter how you look at it, that's not acceptable, right? So if people are waiting a long period of time, that's not helpful. We know that, in terms of prevention particularly, that people need to be seen in a timely manner. If we want this sort of clinical prevention, it's got to be early, and the earlier it is, the better it will be. The whole premise of what we're trying to do is to support people to live with good MSK health, not poor MSK health. And we're waiting. The NHS is very good at waiting for those people to arrive at a point when they need help, rather than us trying to intervene earlier on in that journey. So for us, there's something about how do we get our waiting times down to the level that actually we can do that. The CAD supports that. What I would like to see is that there aren't, we don't have a waiting list, and the CAD is the first thing that they get. They haven't waited 12 weeks. They are literally coming off, and saying, yeah, I'm coming and I'm going to do that because that's the first part of my journey. And that intervention will be really critical at that point for me. It's about really, really defining that is what you need right at the beginning of your journey. So yes, we do have, the waiting lists are problematic, but we're using the CAD as part of that, but also other ways of doing it, to try and reduce those waits to get that early prevention, I think. Adam, sure you want to come in on prevention piece?
Yeah, no, definitely. I think why the CAD is so what Laura and her team have done down in Sussex is so important is because what it showed is that taking a strengths-based, community-powered type approach actually can have a direct impact on short-term demand and on waiting times. I think prior to that, there was a sense that this was a sort of nice to have, that actually it had long-term impact. You often heard the phrase invest to save. We invest now and it might have some benefit further down the line, some years down the line. And of course, when everyone in the NHS and public services more generally is under huge pressure just to save money now, to cut waiting times, to do that sort of thing, the CAD has shown that actually these methods can be used. And I think the insight I take, and the other examples I've given, I think have sort of understood this implicitly, that the key to addressing the challenges, the short term, the financial pressures, the demand pressures that the NHS and others face at the moment is actually better care. There's this overarching discourse that the solution is more efficient care. Let's just process more people more quickly. And what we know is that actually that always backfires, because what happens is people get worse care, they don't get their issues and challenges and problems assessed, so they just ultimately bounce back into the system or into another part of the system and raise demand. And so I think that is, that for me is the real insight that I took. And in fact, when I went down to talk to Laura and Natalie, the managing director of the MSK partnership, I think the first thing you said to me was, we realized the only way we're going to solve the waiting list problem we had was by getting rid of the idea of being more efficient. Being more efficient doesn't work anymore. The only thing that works is better care, and that's how you actually address the issues of demand.
And the other thing I would just add to that is that, if we wait until we get our weights down, it's too late. You're going to have to battle with those weights, whatever you do, and it is about working differently and doing things differently. As Adam says, it's not about being, asking staff to work harder and faster for longer. It just doesn't. That doesn't cut it. You have to do this differently, and I honestly feel that that personalized care approach has been really helpful and successful in doing that.
That's really brilliant. So I think we still have a few more questions in there, Joe. So do we have time to still go through some of those?
Yeah, I think we've got time for a couple more questions. I was just wondering, having been involved in services with long waiting lists, it's so demoralizing. So what's been the impact on staff of being able to approach things differently? I don't know if maybe this is one, Charlotte, you could tell us about.
Sorry, can you repeat that? Sorry, the line was been sorry.
Oh, that's all right. I was wondering about the impact on staff, because when you're coping with long waiting lists all the time and you're on that conveyor belt of patients every 20 minutes and knowing that you're not managing to make a difference to the waiting list, it's quite demoralizing. So how's it been for you being involved in an initiative like this?
Yeah, no, completely. As we know, work in MSK is, like you said, can be exhausting. There's lots of people coming through in your diary and you want to give the best care and everything to them and have those conversations. And like you said, make sure everyone's treated equally and yeah, getting them to where they need to be. And I think, like I said, we do a lot with personalised care here in the service. So lots of training and how to, like I said, manage complexity in those difficult conversations. So I think it's starting to add more of those techniques into our appointments in clinic. And I think, like I said, the several CADs that we are part of, I was part of What Matters, so I didn't say it, I said that earlier, the What Matters to You section. So it was just amazing to obviously just seeing everyone. And I think someone was saying people did have kind of those timed appointments within the hour. So we kind of knew people were just coming in, and so everyone was just holding different timed conversations. It kind of flowed quite nicely. And as Laura said, if people were waiting a bit longer, there was always, like, the admin team were fantastic, in the studio. They were just getting people to just having those conversations and speaking, really. So no, I thought it was amazing, because like I said, it upskilled everyone in the sense of you having conversations all day with different people. And like I said, it was lovely to not have that time and have it, and it just organically ended the conversation. Some people came knowing exactly what they wanted, but others, like you said, just didn't know that you had that time. And it wasn't a panic, like you said in clinic, I've got my next patient at 12:30 because my colleague next to me had a nice conversation for 10 minutes, and some conversations I held were like for 30 minutes to an hour sometimes, because we just needed to get to the bottom of their main concerns. So it's lovely just to have everybody around you. It was really positive.
Oh, Fab, thanks for sharing. That's really good to hear.
Laura, there's one more question in there for you. So it's around, was it a joint decision in terms of getting people off the list once they felt they had what they needed or received the support they got?
Yeah, absolutely. So it wasn't a case of, well, you've got what you need, now off you go. This was very much agreed with that individual about, have you got what you need? Is this going to support you? What else is necessary? And that was very much sort of led and agreed by both partners. You know, sometimes the individual, that person might see 3 or 4 individuals, and so it was about sort of joining up some of those conversations. But essentially, yes, it was a case of, right, you've got what you need. You know where we are if you need us. This is what you need to do if something changes and or you've got concerns. So they were very well supported in the next steps of what to do. So yeah, totally agreed. It wasn't a kind of, well, you're coming here and that's it. You know, some people needed further intervention, so that's what they got. You know, it was very much based on their needs.
Brilliant. And which brings me nicely on to my next question. And this is to both Adam and Laura. I mean, what I'm hearing is, you know, co-production in action, and to the point that you're even empowering the patient to make that choice and decision. So I think this is something we, as like you said previously, Laura and Adam, through your examples, that we need to learn to share that power. And as clinical subject matter experts, that can be really hard for us. So what would be your tips to the leaders present in this room in terms of how they role model that, but also be able to cascade and coach their teams into changing those behaviors? Because for me, that's a real mind shift, you know, in terms of how you do it. And you guys have done it. So I think it would be great to hear some tips from both of you on that.
I think it's a great question. You know, it's not an easy answer to answer either. I think this, you know, we're on a journey. We're still on a journey getting that right. We haven't got it right completely. There are still members of staff who, you know, who will take the medical model style, and you know, it's about changing that culture, trying to shift that, and everybody will be on a different journey. I think, you know, as I said, I think we've had such a good culture within our organisation around personalised care for such a long time that, you know, that is changing, and I think the CAD helped to do that, and to strip away those medical model type approaches, you know, taking the notes and all of this, you know, sitting in a consultation room in a hospital, you know, stripping some of those things away just by merely doing that and saying, just imagine you're having a conversation with a friend, because that's what you're trying to do here, is you're sitting down and having a conversation about everyday things that could be bothering you, and how would you deal with a mate if they did that with you? You know, it's no different, and we have to be equal partners. And it is challenging because, you know, people will say, well, I've spent 10 years training to do this, and you're telling me that I'm not the expert. They're still the expert. They're just bringing a different expertise. And I think, you know, it's understanding the expertise that patient's bringing alongside what you're bringing. So it is a challenge, but I think it needs pushing, and, you know, just sort of, you know, push on the door and keep pushing on it, and people will get their heads around it eventually, I think. Adam?
Yeah, I think, I mean, humility is absolutely key. I think as a leader, modeling that humility, being clear that you don't have all the answers, and that as a leader, but as public sector professionals, you also have to recognize that you don't have all the answers and other people do. And actually, if you connect with others, if you augment your own expertise with the expertise of people outside the institution, you're going to have a better impact. So I think humility is absolutely key. And then the other thing I would say, which, you know, something has struck me recently, is about granularity. I think we often talk about sort of broad values and principles, and those things are absolutely important. But I think sometimes we stop there. And actually, what I think things like the CAD and other examples show, that if you're going to shift mindsets and organizational cultures towards a more preventative, strengths-based type approach, get down into the detail. Really sit down with a team and work out what are the habits, the daily rituals, the little things that you need to change to move towards a completely different way of operating. And that we sometimes forget. And actually, been looking at a lot of the evidence recently that's been coming out of thinking around behavior change. And what it shows is that actually that level of granularity, getting specific, getting down into daily habits, that is really key.
I mean, that's brilliant. And that's just some powerful, simple things that we forget to do. And that's come across so well in what both of you have said, Laura and Adam, and I hope it gives us a lot of food for thought for those who are all present here. I think we've got 1 minute left, Joe, and I believe there are no more questions in the group. I'm just going to quickly skim through, but is there anything else you want to add, or?
Yeah, I think we're on time now. So thank you ever so much, Adam, Laura, and Charlotte, for coming along today. That was such an insightful conversation. It'd be really interesting if anyone's got a moment before they go, just to pop in the chat what you've taken away from today. Was there anything that you're going to go away and think about? What really stood out to you? And for me, it really was those powerful conversations with our patients, but also with our teams and our leaders and those around us. So thank you, Bianca, for coming along and co-hosting the conversation with me, and Matthew and Maria for your work behind the scenes. If you want to find out a bit more about our special interest group in Q, I put the link in the chat. It's the Allied Health Professionals and Quality Improvement Group. You don't have to be a full member of Q to join the group. You can just click on the link. And if you'd like to be involved in a regional group, you can pop your name and email in the chat. If you'd like to follow along with Laura and Adam's work, you can find them both on LinkedIn and see what new initiatives they're up to. And I think that's all from us. So thank you ever so much for joining us, and hope you have a good rest of your day.